Hello guys, I am Dr. Ravindra Savarkar and I welcome you back to Med School. Topic for this video is AV conduction block. This is an overview of conduction system of heart. To understand conduction block better, please watch Basics of ECG Part 2. Link for the same is given here. To watch short video on conduction system, you can visit Med School on Instagram or Facebook. AV conduction block occurs when there is partial or complete block to the passage of impulse from atria to ventricles. There are three types or degrees of AV block. In first degree, block is present at AV node. Sometimes it is physiological, for instance, it occurs due to increased vagal tone. It may be drug-induced with drugs like digoxin, beta blockers, calcium channel blockers like verapamil. Only ECG finding in first degree AV block is prolonged PR interval, that is more than 200 millisecond or 5 small boxes with standard calibration, without any dropped QRS complex. Rhythm strip in first degree AV blocks looks like this, where PR interval is more than 200 milliseconds and every P wave is followed by QRS complex. That means no QRS complex is dropped. In this ECG, PR interval is more than 5 small boxes, that is, it is more than 200 milliseconds, and every P wave is followed by QRS complex. Hence, it's an ECG of first degree AV block. Second degree AV block is further divided into Mobitz Type 1 and Type 2. In Mobitz Type 1, PR interval progressively increases in duration and ultimately there is dropped QRS complex. After dropped QRS, PR interval comes back to its original duration and the cycle is repeated. This is called as Wenckebach's phenomenon. Second degree AV blocks are expressed in terms of ratio. In this strip, for every 4 P wave, 1 QRS is dropped. Hence it is expressed as 4:1 block. In Mobitz Type 1, block is at the level of AV node or bundle of S and QRS complexes are usually normal. In Mobitz Type 2 second degree AV block, PR interval remains constant with each impulse till the appearance of dropped QRS complex. And after drop, PR interval remains same in duration and the cycle is repeated. You can calculate block ratio in this strip as we did for last one. So please write down the ratio of the block in this strip in the comment section. In Mobitz Type 2, block is usually below bundle of S and QRS complexes are usually wide and have bundle branch block pattern. So how does this classification into Mobitz type help? In Mobitz Type 1, block is at AV node or bundle of S, that is in this region. Probability of conversion to complete AV block is less. Even if this block changes to complete AV block, ventricular pacemaker develop at the site just distal to bundle of S, which has inherent rate of approximately 40 beats per minute. That's why chances of life-threatening bradycardia are less. Whereas in Mobitz Type 2 AV block, probability of conversion to complete AV block is high. As block itself is below bundle of S, ventricular pacemaker develops even further in conduction system, where inherent rate can be below 30 beats per minute. That's why chances of life-threatening bradycardia is very high and placement of pacemaker prophylactically is advised. In this ECG, QRS complexes are dropped after every alternate P wave. To know if there is PR prolongation or not, at least 2 consecutive PR intervals should be present there. So from this ECG, it is impossible to know whether it is Mobitz Type 1 or Type 2 AV block. This is called as 2:1 second degree AV block, which is difficult to classify into Mobitz Type 1 or 2 from ECG alone. In 2:1 second degree AV block, QRS complex morphology gives indirect clue about site of block. If QRS morphology is normal like this, block is most probably in AV node and bundle of S region. If QRS complexes are wide and have bundle branch block pattern, block is most likely below bundle of S. In third degree AV block, which is also known as complete heart block, there is complete cessation of conduction of impulse from atria to ventricle. Atria are activated by SA node while ventricles are activated by ectopic pacemaker. This condition is known as atrioventricular dissociation, where there is no relation between P waves and QRS complexes. This is evident on ECG as every P wave is not followed by QRS complex, and PR intervals are also not constant. As inherent rate of ectopic ventricular pacemaker are low, hence ventricular rate is slow, usually below 40 beats per minute. As site of ectopic pacemaker goes further away from bundle of his, inherent rate goes on decreasing. QRS complexes are usually wide, slurred, notched and bizarre. As with rate, as site of ectopic pacemaker goes further away from bundle of his, aberrancy of QRS complexes goes on increasing. In this ECG, every P wave is not followed by QRS complex with varying PR interval. PP interval is 2 large boxes, so atrial rate is around 150 beats per minute, whereas RR interval is 11 large boxes. That means ventricular rate is around 25 beats per minute. QRS complexes are wide with slurring and notching and looks bizarre. All these features are suggestive of complete heart block. Complete heart block is life-threatening condition if not treated immediately, and cardiac pacemaker placement is indicated. Thank you for watching this video till the end. If you have any query or suggestion, please write it down in comment section. If you like my work, please like this video and share it with your friends. To get notified about next video upload, please subscribe to the channel and hit the bell icon. Till next video, take care and keep learning.